masterclass series on reoperations on strabismus surgery. To those who don't know me, I'm Tamara Wignansky-Jaffe, the present IPOSC president. IPOSC represents a family of 92 national and supranational societies. We encourage all of you to log into our new website where you'll be able to see all our webinars, and this one included in a few days. But you can also get to know the IPOSC activities and other things you can log in and help us do, such as the research committees, IPIT, SIBA, and others. Just some housekeeping information. During the next hour and a half, we will have 6 presenters from different global locations. Each presentation will be followed by a 5-minute Q&A session. Please enter your questions in the Q&A box, not in the chat box. And if the speakers do not reply to your questions orally, you will see the answer on the website a few days afterwards. So with no further delay, I will pass the webinar to Rosario and Giovanni. Thank you for all the presenters, thanks for the moderators, and thanks to all the members who are joining us for this webinar. Enjoy, and remember not to hesitate to ask any questions. Thank you.
Thank you very much, Tamara. Good morning, good afternoon, everybody. And I also thank you for joining us today in this masterclass of strabismus reoperations. My name is Rosario Gomez de Liaño, and I am moderating this session with Dr. Giovanni Marcon from Italy. Hello. And it's a very big pleasure to have you here and have such a distinguished and outstanding panel of experts with us. We have really a very attractive program focusing in reoperations and complex post-operative conditions. And we will begin with Dr. Ian Marsh. Please, next slide. Yeah, from Manchester, that he will speak us on botulinum toxin, but especially on bupivacaine in residual and consecutive strabismus. Dr. Ian Marsh is a very well-known strabismologist. And I will have to say that maybe he is the long-standing experience now with botulinum toxin and bupivacaine. For me, it's a very generous man in terms of teaching, and your work for me is very inspiring, and I'm sure it's going to be very extremely valuable for our community. And then we will go to Professor Chen Zhao from Tianjin, and he will discuss reoperations in intermittent exotropia, sharing his expertise in this field. He has a very strong professional career, and he has different positions in matters of chairing and committee members and editorial boards. I'm sure this presentation is going to be also a very attractive one. Then we will hear about management of stretched scar, slipped muscles, lost muscle, and strabismus surgery by Dr. Daniela Cioplean from Bucharest. And Daniela is also a very well-known specialist, and she is the head of the strabismus department of the Pro Clinic. She is a really good teacher and practice in many media, with a CIBER site, with the fellowships that we have, that she has, and that also in the FIBO exam. And also different position in societies, as for instance, Vice President of ESA Association. Then we will move to Professor Hala El-Hilali from Cairo University in Egypt, and she will present the management of antielevation and adherential syndrome after inferior oblique surgery. Dr. El-Hilali, she's a professor of ophthalmology in Cairo University. She's an amazing, good teacher and has developed a lot the specialty in her country. And now she's vice president of the Egyptian Association, and she is the president-elect of the International Strabismological Association. Our next speaker will be then Andrea Molinari from Quito, Ecuador, that she will talk about reoperations after transposition procedure, which is a difficult topic. Dr. Molinari, she works in Quito in the Metropolitan Hospital. She's associate professor. She's also director of a fellowship. She's the president of the International Strabismological Association, and she's a very, very, very good speaker. And next, but not least, we will conclude with Dr. Luis Ospina, who will address on reoperations in Duane syndrome. And Dr. Luis Ospina, he works in Montreal University in Canada at the Centre Hospitalier Saint-Justin. It was amazing to see how much improvement he has done in this institution. He's a professor at the Montreal and John Flynn University, and he's the fellowship director of the pediatric ophthalmology and strabismus at that university. So without further delay, I would like just to remember that any questions that you would like to do, please do it on the Q&A box. And without further delay, I would like to pass the word to Dr. Ian Marsh, that he will present about Bupivacaine in the management of strabismus.
Thank you, Rosario. So I'd like to talk about Bupivacaine and the use of botulinum toxin for residual and consecutive strabismus. There's been lots of information about this, particularly in animal studies, going way back for 20 odd years, back to 2004. And in fact, if you look at the work that's going on, it looks as if the rabbit model is the one that works best for humans. And in fact, what this tends to show is that after an injection of bupivacaine into an extraocular muscle for a rabbit, you get initially loss of the nerve, the muscular fibers, followed by hypertrophy and increasing in the cross-sectional area. The landmark paper from the point of view of adults was published in the British Journal of Ophthalmology in 2007 by Alan Scott. And he used 4.5 mils of a 0.75% solution into the right lateral rectus of a patient with diplopia and a 14-diopter esotropia. The paresis in the muscle persisted for 7 days, but the abducting ability returned, and there was a progressive improvement in alignment. And in the paper, he had images from the extraocular muscle that had been injected at the same point in 2 separate occasions, one before and one after the injection, showing the enlargement of the lateral rectus. There are human studies going back to 2009, and Alan Scott followed this up by a paper in 2009, and then a whole variety of other papers, including at the bottom on the left-hand side, a review article on looking at the efficacy of bupivacaine for the treatment of strabismus. There is a little less literature in terms of treating with bupivacaine and botulinum toxin, but on the right-hand side, there is a review article from 2022 looking at the treatments. So from my point of view, I started injecting bupivacaine into extraocular muscles in 2008. And I looked back at the data that I've done over the period of time from 2008 to 2022. At the time I started looking in 2022, I'd done 142 injections. I've now done 288. And of the initial data, 16 had had a couple of injections and 2 patients had had 3 injections. The vast majority were in lateral rectus for esotropia, but there was a significant number that had had botulinum, had bupivacaine into the medial rectus for an exo, and a small number who'd had inferior rectus treatments for hypertropias. If I look at bupivacaine alone, and this is the initial group, small angle esotropia was in 36 cases, distance esotropia of aging in 7, etc. And you can see the data there. And if we separate this data out a little bit more, you'll find that you can look at what the outcomes of treatment were. The problem that we have is that we look at actual numbers. So we had a starting deviation, for example, of 20 diopters, and we ended up with a finishing deviation of 5 diopters. That tells you that you've got a 15 diopter change. So what I've done is I've looked here at what the effect of the treatment was in terms of prism diopters, and more importantly, the percentage of angle reduction. And if you look in the esotropic group, the ones that had bupivacaine for esotropia, 52.89% improvement. So they had a halving of the angle. And similarly, in the exotropia group, again, 51% change in angle. The numbers, obviously, in the deviation were quite small because we're talking about small angled treatments. If we look at the outcomes, excuse me, in terms of small angle esotropia, you'll see that 86% of the distance esotropia of agings were cured with a single injection of bupivacaine, and 14% went on to have surgical intervention. There was a small number of DNAs in the other small angle esotropias, but again, a significant number of patients were cured with the treatment, and a small percentage, about 1/3, went on to have surgery. If we look at the exotropia outcomes, they're a little bit more mixed, but again, the take-home message is that there was a significant number that were treated with an office treatment and not having to go on and have surgical intervention. So if we look now at what I have been doing in the last few years, I'm looking in a longitudinal observational way of all patients that are having bupivacaine and botulinum toxin. Now, I started these treatments in 2014, 11 years ago, and initially I was using 0.5% bupivacaine, which is the only one which is commercially available, and I was injecting 5 mils into an extraocular muscle to give 25 milligram dosage. Obviously, 5 mils is a very large volume. The botulinum toxin dosage that I've used has been in the same in all cases. From 2022, I was able to obtain 3% bupivacaine. So consequently, you can give a slightly larger dosage of 30 milligrams by using a much smaller volume of 1 mil. And from 2022 to current times, I've been using 3% bupivacaine as opposed to 0.5% bupivacaine. If we look at the outcomes from the point of view of the injection treatments, from 2014 to 2025, I'd done 47 injections in 32 patients, and I had complete data for 41 episodes. And when I talk about complete data, I'm mentioning a 3-month follow-up. There's 1 DNA in this group, and 5 still haven't received the minimum follow-up period. 1 has had 6 treatment episodes, but this group contain the 0.5% and the 3% groups. So the average preoperative deviation was 26.5, and the average post-op deviation was 17.7. Just to point out that there were 6 blind eyes and 3 with previous multiple operations. All of these had the risk of anterior segment ischemia, and 14 out of 32 patients achieved an acceptable position and didn't need surgery or were controlled to aphoria. In the 0.5% group, so there were 17 patients in 17 treatments. There were no DNAs, and I had complete data for all of these patients. The average preoperative angle was 23.5. The average postoperative angle was 14.1. 6 out of 17 didn't actually need any further intervention, and 4 out of the 7 were blind or had multiple surgery and were at risk of anterior segment ischemia. The problem that I have with measuring in prism diopters is that we are actually measuring the total deviation. We're not looking at the latent deviation, and perhaps we should be thinking about doing simultaneous prism cover tests as opposed to alternative prism cover tests. If we look at the 3% group, which is over the last 3 years, the primary group that never had any treatment before with local anesthetics, there was 15 patients. The preoperative angle was 31.2, and the postoperative angle was 20.9. But 4 out of the 15 needed no more intervention. So we'd actually cured, in inverted commas, 11 of these particular patients. In the total group, which included those having repeat treatments, there were 30 treatments in 19. One of these patients has had 4 episodes, and in fact has now had 6. Preoperatively, 28.8, and now postoperatively, 20.3. I've got 24 with complete data, 5 which are still awaiting assessment, and 1 has failed to turn up. 3 out of the 19 ended up having surgery. So 6 of the 19 have achieved a satisfactory alignment with 1 or more treatments. So there were no complications seen in any of these patients. It's a small study group, and there are only really very small angle changes of up to 10 prism diopters, which is small compared to previous studies. But this was a very amorphous group with multiple different pathologies present, and the best outcomes were achieved in those with potential binocularity. But it was a useful treatment for those unsuitable for surgery, for example, those with a high risk of anterior segment ischemia, lots of multiple operations, or patients not wanting more scarring from surgery. Repeat treatments seem to increase the effect, but the change in angle is less. I'd like to just go on to talk a little bit about a work that was published earlier last year, looking at bupivacaine injections for the treatment of age-related distance esotropia. We looked over a period of 2 years, looking at local anesthetic bupivacaine and lateral rectus resections. We had 14 patients in 14 injections in 13 patients. The average preoperative angle was 7.3 and the average post-op angle was 4.1, with a follow-up of 143 days. 5 out of the 8, or 63%, were cured just with an office procedure. 1 out of 8 had a partial success, and 2 out of 8 had no change in angle. And I would say that this is a possible alternative to surgery if patients are prism intolerant. So my practice now, where do I use local anesthetic? Well, if I've got somebody sitting in front of me with small angles of 10 prism diopters or less, who may not be fit or want an operation, I will also use it in larger angles where patients don't want surgery to reduce the size of the prism. I use it now as an initial management of distance esotropia of aging to reduce or eliminate prism, particularly if the angle of deviation is 10 prism diopters or less. I offer it to near exotropists, but I now mainly use inferior plication of the medial rectus, and I use it in combination with botulinum toxin when surgery might risk the eye, for example, a blind eye, a thusical eye, or previously failed surgery. So what work is required from now on? So we've got 4% bupivacaine available. Does this give better effects? We're not sure. How well does it work on previously operated muscles? Scott showed that, in fact, if you had a dead muscle, it wouldn't work at all. But if you've had previous surgery, does it work on that? What's the optimal dosage for both Botox and bupivacaine? As I said, I've used Botox in the same dose all the time. If we increase the dose, do we get better effects? That's another question. Would it be of better effects if we gave the bupivacaine and the botulinum toxin at different times? Would it be better if we gave the bupivacaine 4 and the Botox a week later? Would it be better if we gave the Botox first and the bupivacaine later? And obviously, we need a satisfactory survey of the patients to see whether they're happy with this. So I'd like to say thank you for your attention and just point out that in paintings, you'll pick up some very interesting ocular motility abnormalities. So the patient on the left-hand side has obviously clearly got a 4th cranial nerve palsy. The second one in the middle has obviously got a 6th cranial nerve palsy. And the final one has got a family of patients who've got congenital nystagmus with face turns. Thank you very much.
Thank you very much, Ian. That's really a very excellent topic and very many new insights that you told us. I remember the beginning of this technique with these huge volumes. We had a big inflammation intraoperatively in those patients. So we have several questions, and they most address on the post-operative management of those patients. So if you find particular difficulties after bupivacaine injection, or how do you find the muscles, or if you change your numbers in terms of surgery in those patients?
So from the point of view of the delivery, it's done using obviously the electromyogram, exactly the same. Post-operatively, you do get some inflammation, which I don't actually treat with anything unless it becomes significant. So none of the patients go home with drops or anything like that. I sometimes will use oral anti-inflammatories if they do get quite a lot of inflammation. The most important thing is if they are binocular, is that you do get a significant underaction of the muscle that you inject. So, for example, if you inject the lateral rectus, they go markedly esotropic. So these patients will, when they come in to see me, are always told that they have to wear a pad for at least 48 hours post-injection, because the eye goes in and then will come back to where it was previously. And so they have to be able to be accompanied when they come to the office, because they can't drive home with a pad on. I noticed in the Q&A that there was, is there any difficulties during surgery after bupivacaine? No, the eye muscles are exactly the same after having had the bupivacaine. Obviously, they will be slightly on the larger side. In terms of the dosage of surgery, there's a question about whether the dosage of surgery changes. The answer is it's difficult to say from that point of view, because a lot of these patients, if they've tolerated me giving them bupivacaine under local anesthetic, I will often operate on them using adjustable squint surgery. There's a question there.
Yes, there's a question on, do you use always Botox and bupivacaine, or when do you use only bupivacaine?
So for larger angles, so if I've got a 20 diopter deviation or more, I will use bupivacaine and Botox. If it is less than 20, I'll usually give them bupivacaine to start off with. And if they don't get a good enough effect, I will then add in the bupivacaine at the Botox at a later stage.
And which is the, how long does it take until you say that's an optimal effect of bupivacaine?
So what I used to do when I first started doing bupivacaine was I would give them the injection and I would review them at monthly intervals so that I could actually see those particular deviations, the change in deviation. So if they started with 20 diopters, at 1 month they might have 15 diopters, at 2 months they might have 10 diopters, and so on. So you could see the slope of the curve. But nowadays, because of difficulties getting patients into clinics, what I do is I give the botulinum, I give the bupivacaine, and I review them at 3 months, because that's the optimal time that the deviation is the best possible outcome. I have seen the occasional ones that get a little bit better after 3 months, but the vast majority, it's 3 months.
And the very last question, because we have many, but we have to skip to the next presentation. Do you find, did you ever have MRI results? If you have really enlarged the hypertrophy, you have an hypertrophic muscle, as Alan Scott said, or you don't find them?
Well, from the point of view of the work that's out there, it shows that there is hypertrophy of the extraocular muscle after you've injected it. In a cash strap system that we have in the UK, I tend not to MR them before or after. It's a little bit academic. I treat and see whether it works.
Okay. So thank you very much for this very nice discussion.
Thank
Giovanni?
you.
Yes. Thank you, Rosario. So we move to the eastern part of the world where intermittent exotropia is a very frequent strabismus. And it is my distinguished pleasure to introduce Professor Chen Zhao from China, Shanghai. And he will speak about reoperation in intermittent exotropia. Please, Professor Zhao.
Hi, thank you, Dr. Marco, for introduction. Hello, everyone. I'm Chen Zhao from Shanghai. I am the ENT hospital, and today I'll be talking about the reoperation in intermittent exotropia. IXT. IXT is the most common type of strabismus in East Asians, and the prevalence of IXT is at least twice of that of esotropia, as you can see here. So IXT is very common, but it's still very challenging in terms of the treatment. And one reason is that the recurrence and overcorrection are both very common after first operation. So about 20 to 30% of those patients would eventually need a second operation. So today, I'll be talking about 3 situations for reoperation of XT. Number 1, consecutive esotropia. Number 2, residual exotropia. Number 3, vertical deviation together with the overcorrection or undercorrection. So for consecutive esotropia, there are a number of non-surgical options that you can consider before reoperation. But today, I'll be focusing on the indications for reoperation, and those indications include a clear sign of muscle-related complications, and you got to fix those problems as soon as possible, or severe early overcorrection, or a patient is very young with significant risk of loss of stereopsis, or a patient present persistent esotropia after standard non-surgical treatment. So how we plan our next operation. So if the patient previously received BILR resection, then I have to first evaluate the motility. If the abduction is limited or a dysfunctional ILR is suspected, then advancement of the previously recessed lateral rectus, ILRA, is the first option. And ILRA can be combined with the ILR resection, as you can see the 2 pictures here. And this protocol works pretty good for me because that way you can remove some of the stress scars. And IMR resection is an alternative, especially when IMR is very tight. And for the target angle, I have to leave a small angle of esotropia at the early stage post-operation. And adjust suture is always recommended whenever it's feasible. And if a patient previously received unilateral resection at the resection, then I have to first determine the responsible muscle by first suction test. If the ILR is very loose or abduction is limited, then I will do ILR advancement. If the IMR is very tight, then I will do IMR resection. And sometimes I will do both if there's a large angle of esotropia. So the dose-response relationship is very critical for the second operation, but on this regard, previous studies have provided different numbers, as you can see here. So on this regard, my team has done a regression analysis based on 42 patients with consecutive esotropia, and we found 1 millimeter of ILR advancement can correct 3 present diopter of ET, and once ILRA is combined with IMR resection, then 1 millimeter IMR resection can correct 3.7 present diopter of ET, and this formula works pretty good for me. So the second situation for reoperation is residual exotropia, and the risk factor for residual exotropia include early age of onset, large angle, poor binocular function, and hyperopia. So again, how we plan our next operation? So if a patient previously received unilateral resection and resection, then the second operation will be easy. You can first choose contralateral ILR resection with or without IMR resection, depending on the residual angle of XT. And the target angle will still be slight immediate overcorrection. And the surgical dose can be planned at that of first time because we are working on fresh muscles. And if a patient previously received BILR resection, then the second operation will be more difficult. So if a patient has small to moderate angle of residual XT, less than 25 diopter, then you can first choose unilateral IMR resection or unilateral ILR re-resection, and ILR can be re-resected. And one paper demonstrated that large amount of unilateral IMR resection, up to 10 millimeter, is effective and has better outcome than standard BIMR resection. If a patient has large angle of residual XT, more than 25 present diopter, then unilateral ILR re-resection with IMR resection is preferred. BIMR resection can be used when necessary, but the dose-response relationship is very unpredictable for this protocol. So regarding the dose-response relationship, it has not been well defined under the circumstances. Previous studies have provided significant variation of dose response for IMR resection, and for the effect of ILR re-resection, it has not been even studied. So again, my team has done a regression analysis based on 58 patients with residual exotropia, and we found 1 millimeter of LR re-resection can correct 2.5 diopter. And once LR re-resection is combined with MR resection, then 1 millimeter MR resection can correct 3.4 diopter of residual active. And the third situation for reoperation is that the patient has either overcorrection or undercorrection together with vertical deviations. And such vertical deviation can be associated with AV pattern, DVD, superior rhabdoid overreaction, or inferior rhabdoid overreaction. And under these circumstances, mild to moderate vertical deviation without obvious oblique dysfunction can be addressed with vertical transposition of the horizontal recti. But if oblique abnormality is apparent, then it should be treated simultaneously. And I can give you two examples. So this boy has previously received BLR resection for 7 millimeter with BIO transposition, but after the first operation, he still presented residual activity for about 20 some diopter with right eye hypertropia for 8 present diopter, and his right inferior oblique shows a little bit overreaction. So for this case, I did right LR re-resection for 3 millimeter and right IMR resection for 6 millimeter to correct the residual activity. And the two muscles were shifted downward for about 2/3 muscle weight to correct the vertical deviation. And this result turned out to be really good. But for the second case, this girl previously received a left eye recession and resection with BIO tendectomy. But after the first operation, she still presented very evident overreaction of bilateral inferior oblique with residual active for about 30 present diopter. So in this case, I did right eye ILR resection with MR resection to correct the vertical deviation. I also checked the inferior oblique, and I found residual fibers of inferior oblique at its original path in both eyes. So I transpose those residual fibers accordingly. And then the result turned out to be very satisfied. So to summarize, for the reoperation activity, you first need to evaluate the mechanism of recurrence or overcorrection. You need to use some reasonable surgical skill, like possible dose response formula, adjustable sutures. You need to set up a right angle, and you always need to communicate with the patient and parents really well. And with that, I'd like to thank you for your attention, and I'm ready to take your questions.
Thank you so much, Professor Zhao, of this very interesting presentation. And waiting for some questions from the audience, I would like to ask you concerning consecutive esotropia, because this is an important complication, especially in young kids, where you remember that we may have loss of binocular vision. Which is the age where you plan to prospect surgery to the parents, the minimum age that you operate your children for?
You mean
intermittent XP?
For the immediate second operation, right? That's your question?
No, just the first one, to avoid consecutive ET.
Well, if the patient have congenital exotropia or has a constant exotropia, I think the minimum age may be 1 or 2. But if the patient has intermediate exotropia, I think the minimum age would be 3 or 4 years of age. I wouldn't do that. Before 4 years old.
Yeah. Okay. And we have a question now, and how much time do you usually wait on a patient with moderate angle consecutive ET for prospecting reoperation? How much time do you wait to reoperate in a medium angle consecutive ET?
Well, before the second operation, there's a lot of non-surgical options that you can take. So first, I will wait like a couple of weeks, like a month, to see whether the alignment can adjust back. And after 1 month, I will maybe put down some prism. The prism can correct this consecutive esotropia in roughly like I think like 2/3 of those patients. about 33% of those patients can take off their prism within the year and within 3 years. But I mean, this is not from my study. This is from a study published by Korean group. That paper says that about 80% of patients, I mean, varying prism, they can eventually take off the 80% of the patients can eventually take off the prism with very good stereopsis. So I mean, that size, I mean, having said that, I would wait, I mean, as long as these patients have good alignment with this prism. But if I mean after those this non-surgical treatment, if this patient still have misalignment, still have esotropia, then I wouldn't wait for more than 3 months, because that way, you know, that would decrease their opsis very fast. So I will do the second operation if the non-surgical treatment doesn't work. So I wouldn't wait for more than 3 months.
Okay. This is a very quick answer, please. In patients with small angle residual XT postoperative, do you consider a conservative treatment like intentional myopic overcorrection?
Well, I mean, I used to try a little bit. I mean, also with some training with this. I mean, the myopic overcorrection, but it seems that it doesn't work really well for my patients. I mean, if this patient have really good controls, I mean, even though they have very big angle of residual activity, but as long as they have really good control, so I can wait for a bit longer. But I don't think, I mean, if the patient doesn't have really good control, I don't think, I mean, this myopic overcorrection can help those patients. So I would just go ahead for second operation.
Okay, thank you. And what about adjustable sutures? Do you use them in children, or starting which age?
I think I would start at, I mean, that depends on how the children will cooperate with you. I mean, for some kids, I mean, even they are only 12 or 14 years of age, they can cooperate with you really well. So you can, I mean, evaluate before your operation. Then maybe you can use adjust suture and adjust that suture like 1 day or a couple of days after the operation. That's different, individual difference. It really depends on how the kid will be cooperated. So I think the least age will be like 12, something like that.
Okay. We have a question from Portugal. Do you change your protocol, and I think surgical protocol, according to the degree of binocularity of the patient? Or you don't take into consideration this?
I normally just have one formula, dose response formula. But when this patient have very poor binocular function, I would potentially increase a little bit the number, just like by 1 millimeter more than usual, just a little bit.
Okay. And in your opinion, what are the most important contraindications for reoperating a patient? Any reason why you do not want to reoperate a patient?
I mean, well, that's very good question. I mean, if the patient have if the patient, have some adhesive tissue, around the muscles, I wouldn't operate right away. I would evaluate, I have to wait for a while. Or even, or if the patient have small residual angle or small concentric esotropia, but they want reoperation right away, then I would persuade them to wait for a while. For some circumstances, I would wait for a while. I think the least situation I wouldn't do the second operation is that patient have very potential risk like adhesive syndrome.
Thank you so much, Professor Zhao.
Thank you, Dr.
We need to move to the next presentation. Rosario, please go on.
Yes, thank you, Professor Zhao. And then we will go to the next speaker with Daniela Cioplean. Can you share your slides? And she will be speaking in a very challenging situation that is the stretch scars and consecutive exotropias.
Hello, everybody. Thank you to IPOSC for inviting me to talk in this webinar. I have no financial interest. Sometimes in strabismus surgery, poor technique or other circumstances can favorize or produce a further new abnormal reattachment of the muscle to the sclera as stretch scar, as you saw in the previous presentation, a slip muscle, or even a lost muscle. The surgery result is a consecutive or a recurrent strabismus. The stretch scar is produced by an abnormal healing of the new reattachment of the muscle to the sclera, as Irene Ludwig very nicely described it in her books. Different causes have been incriminated, but mostly primary collagen disorders, metabolic disorders, prolonged steroid treatments, and we have to be aware about this, and also the possibility of premature absorption of the sutures. These are two examples of stretch scars. In two cases of long-standing strabismus, usually affects all the operated muscles. The length of the scar is usually small, and the muscle function is good to fair, but not perfect usually, and affects all the operated muscles, and the scarring area is robust. The deviation is slowly progressive, but not always. I'll show you a case. This is an example of a possible early suture resorption in a child who developed consecutive XT in the first weeks after surgery with a deduction limitation on both eyes. And it was absolutely symmetrical after medial rectus recession. He was reoperated, the stress scar was resected, and the new insertion into the sclera was done with non-resorbable sutures, and the result is stable after 10 months after surgery. If stress scar is present, we need to resect it. We can plicate only in small deviations. In resections, we can add the muscle advancement and antagonist weakening procedures if we have large deviations. Hangback sutures can be useful for the final adjustment using the force reduction test, and also botulinum toxin, but the most important thing, and we don't have to forget this, is to use non-resorbable suture as main sutures or to add a non-resorbable suture as reinforcement. In our case history, the stretch scar length we presented a few years ago, paper was up to 5 millimeters. The resection on the affected muscle was 15 or even 20 more than in a normal muscle according to the nomograms. We cannot offer the right numbers, but I suggest maybe to try the Ludwig's formula if we deal with a stretch scar. The slippage is defined as the retraction of the muscle posteriorly within its capsule, only the capsule remaining attached to the sclera. The empty capsule portion attached to the sclera is called pseudotendon. The main cause of a slippage is our poor technique, which doesn't allow to the muscle to securely attach to the sclera. There are several factors which can favorize the muscle slippage, but mostly muscle contracture and stiffness. And it is very important to recognize a slippage if present. I'll show you a terrible case. This is a case of thyroid orbitopathy. It's a busy slide, but I hope you understand. You can see the huge overcorrection after a moderate. The second surgery was a moderate superior rectus muscle recession, and the disease was reactivated, and the healing period was coincident with the left inferior rectus involvement, as you can see in the MRI. When we suspect a slip muscle, when we deal with limited deduction in the field of action of the suspected muscle, and usually is accompanied by proptosis. This is an important factor. The deviation is usually progressive, and sometimes a severe slippage can mimic a lost muscle. Except the classical signs of recognition described in the books, there is a significant difference of volume, color, vascularization between the muscle and the pseudotendon, as you can see in these pictures. In my hands, because I use for several years, trypan blue coloration is a very helpful tool because this tints only the connective tissues, and you can see much better the demarcation between the muscle and the pseudotendon, and it's available also for stretch scars. Strategy, this is an example of consecutive recurrent XT with a -30 pre-diopters deviation in primary position with a deduction limitation and the left slide proptosis and also incompetence. Don't forget incompetence when you suspect slip muscles. As surgical approach, after muscle isolation, I applied a non-resorbable traction suture on the muscular fibers in order to expose the muscle and to safely anchor it with the 6-0 vicryl. Left down, we can observe the resected avascular pseudotendon, and the right down, the medial rectus muscle reinserted at 9 millimeters from the limbus. Because the total length of the avascular pseudotendon was very large, 15 millimeters, and the medial rectus was very tight, I injected also 2.5 units of botulinum toxin in the medial rectus. And I did this after I recessed a little bit the lateral rectus, about 5 millimeters. And this is the result 3 months post-op. The patient is orthotropic and she kept this position very well. Repairing slip muscle can correct a very large consecutive XT with only 2 muscle recession. And as a general surgical strategy in long-standing very large deviation, weak the antagonist first, isolate the pseudotendon until the muscle can be seen, isolate deeply the muscle from the surrounding tissues, apply traction sutures if necessary to pull safely the muscle, expose the muscle, safely insert the suture into the muscle, resect the pseudotendon, and safely secure the muscle into the sclera, advance it if necessary, but not too close to the limbus. Use the force reduction test and botulinum toxin if necessary. What happens if the muscle remains or becomes totally unattached to the sclera? This patient had 2 previous resections on the left medial rectus. I did the third one because of my superficial bites, probably. Into the sclera, the medial rectus muscle was totally detached 2nd day post-op. But the muscle was safely recovered 1 week after, easily because the suture was visible on the detached medial rectus and the muscle was reinserted at the intended position. 8 years later, he's still ortho with normal reduction. The main purpose in a lost muscle is to recover the muscle. The most difficult to find is usually the medial rectus, as we all know. MRI is very important, and if you can have it, do it. The ipsilateral antagonist weakening is usually necessary. The surgeon assistant needs experience in order to achieve the best exposure without tensioning the already very retracted muscle. And all the maneuvers should be very gentle. In a late surgery, if some attachments to the sclera are present, isolate and follow them until the muscle becomes visible and treated as a severe slip muscle, as described before. If no attachments are identified, use hand-by-hand maneuvers, dissect carefully the plans following the orbital wall or anatomical connections until the muscle is identified. You can use Trip Blue for that. I use the same previously described traction suture with non-resorbable suture for a better gradual exposure and muscle final reattachment. In case of the muscle cannot be found, of course, we can do a transfer, but we have to preserve vascularization, and this is a very important thing. In conclusion, any abnormal reattachment of an operated muscle should be approached by repair as the first intention. Repair also conjunctiva because it's very important, and suture only the epithelium. Resect the pseudotendon on the stress scar or the stress scar, add the muscular advancement if necessary. Consider the antagonist weakening in long-standing large strabismus and consider non-resorbable suture. We don't have specific nomograms for such cases, but remember larger amounts for resection or resection plus advancement, more in slip muscle, about 30% usually. Follow your good instincts, be gentle, preserve vascularization, and stop if your surgery becomes unproductive or dangerous. Target a good alignment at the end of surgery under general anesthesia, and a small overcorrection 2nd day post-op is a good sign. Recovered reduction is also a very good sign 2nd day post-op. I would like to thank you very much for your attention and to invite you in Bucharest next year. Thank you so much.
Thank you very much, Daniela, for this very, very special talk. I have some questions from the audience that asked to you, and I could summarize some of them in one. So, based on your experience along the years, what have changed? I mean, do you use different sutures in stretched muscles or slipped muscles? Which is your target angle in slipped muscles on a stretched muscles? And if you also use non-reabsorbable sutures in your first surgeries, in case you think you're going to have a risk of consecutive ICSO?
I use non-resorbable suture, because I'll start with the first question, only if I'm sure that that patient has a stretch scar. I don't use it in slip muscles. I don't consider it to be very necessary. And sometimes even in stretch scars, I don't use it. I use the resorbable, and I add, as I showed, 2 extra non-resorbable suture on the 2 halves of the muscles, because I don't want to use too much non-resorbable sutures there, but I use them as a second safety tool. The second question was?
Which is the target angle? Your target angle.
The target angle. At the end of surgery.
And if it is different in a stitches or in a stretch scar?
In both, I think my target is the same, but I'm a little bit, maybe I want a little bit more ET on the slip muscles. In the stretch scar, I'm very happy if the patient is ortho or a little bit overcorrected on the table, a little bit of overcorrection.
And how do they How do they do long term, those patients?
Very well.
Very
well.
Okay.
Very well, especially if we recognize the problem. Because if we don't know that we have a slip muscle and we consider that is a muscle, the risk is to resect only a part of the pseudotendon, because sometimes it's not so obvious that it's a stretch scar, especially in very late cases. And you just resect the pseudotendon and you insert the sutures in the pseudotendon, in the remaining pseudotendon. And in the next weeks after surgery, you will see a reoccurrence, which is very bad. That means we did something wrong. Regarding the stretch scars, it is difficult. I don't have the possibility to take the tissues and to go to the lab. I don't have funds for this to make a real research, as some other colleagues can do. But I suspect that when I see it, sometimes the aspect is a little bit different than the slip. The slip, that portion is, you can see through the pseudotendon. This one is a little different and is small, and it looks for sure that you don't have muscle there. It's the attachment area it doesn't look like a real muscle. And these are very tricky cases, but when we have this aspect on all the operated muscles, this is for sure a problem with the patient healing, I think.
We have so many questions for you. But we'll go to the chat. I will summarize with 2 things, because one is if instead of when you take the stretch scar, you can resect it or you can plicate. If you plicate, which are your changes in your technique?
I plicate when it's small.
Yeah.
When the portion is very, and the angle of deviation is small, I used to do this because I had some situation with, I don't know, 15 pre-diopters or something. So then I prefer to plicate, but I use non-resorbable because otherwise,
well, and one that
nothing happens.
I think is interesting because they asked if you can repeat a little bit about your technique of the trip and blue. What are you looking for with a trip and blue?
I want to see exactly where the muscle is, because if you clean very well all that you as isolated as a muscle, if you are very confused and you don't know it's a stretch scar, it's a slip muscle, if you put few drops of trip and blue, the recommended concentration is 1%, but I don't have this concentration. I use 0.6. But as you saw in the pictures, you can see the difference. The color, the color goes only into the connective tissues, meaning in the pseudotendon or in the stretch scar. It doesn't go into the muscle. The muscle remains uncolored. So, but for this, you have to see exactly what you have there, because if you don't isolate correctly all those tissues, it can be very, very tricky. It's very important to see what you got there, and to see exactly the insertion, and to see the muscle along his pathway, going back to the orbit.
The last, very brief, before I pass to Giovanni for the next talk, which tables do you use for the amount of surgery? That was a question from Ospina.
Yes, as I said, I don't use tables too much, but the tables are very useful, because when I do, for instance, pseudotendon resection, I know that it can be the equivalent of muscle resection, but the resection on the nomogram is 30% less than this. For instance, I give an example. I resect 10 millimeters of pseudotendon. This is for me the equivalent of 7 millimeters resection, something like that. This is some orientative tool. But of course, it can be resection plus advancement, of course, but usually it should be significantly more than in a usual resect procedure, especially the resection.
Thank you very much, Daniela.
Welcome.
So thank you, Rosario. We move to the south and we go to Cairo, Egypt. This is my pleasure to present Professor Hala El-Hilali. She will talk about the management of anti-elevation and adherential syndrome after inferior oblique surgery. But before I go, you go, Hala, I want to specify that she has pointed out that she is the former director of the pediatric ophthalmology unit in Cairo University and not the actual one. Thank you very much, Hala, for this, to specify this.
Thank you. Thank you very much. Thank you. I will share my slides. So I'm honored to be part of this webinar. I have no financial interests. Transposing the inferior oblique insertion anterior to the equator converts the inferior oblique force vector from elevation to depression, or rather anti-elevation. And this has proved effective in treatment of dissociated vertical deviation and inferior oblique overaction. In anteriorization of the inferior oblique muscle, the neurovascular bundle acts as the inferior oblique functional origin. Placing the inferior oblique insertion more than 1 millimeter anterior to the inferior rectus insertion, or spreading it out laterally, will increase the tautness of posterior fibers. This augments the force vector directed inferiorly and results in defective elevation in abduction. Additional factors that contribute to anti-elevation include scarring around the inferior oblique muscle acting as a tether, as well as placing sutures far from the inferior oblique insertion prior to detachment of the muscle of the globe, and this will result in an inadvertent resection effect. Clinical characteristics of anti-elevation include limitation of elevation of the abducting eye, marked upshoot of the contralateral adducting eye, V or Y pattern, extorsion, hypotropia in primary position in unilateral cases, absence of restriction to passive elevation in adduction, absence or mild restriction to passive elevation in abduction. Management options for anti-elevation syndrome include performing recessions of the inferior oblique muscle, denervation extirpation, inferior oblique nasal myectomy, as well as extirpation denervation with inferior rectus recession for cases with unilateral anti-elevation and hypotropia in primary position. The first case I'm presenting is a 6-year-old boy who underwent bilateral medial rectus recessions and inferior oblique anteriorization in 2023. He later on presented with left hypotropia, 14 prism diopters, with left in primary position with left fixation preference, as well as left defective elevation in abduction. On table, force reduction test showed that there was no restriction to passive elevation in abduction. Conjunctiva was incised. The inferior rectus was placed on a hook, and it appeared a little bit tight. There were minimal adhesions around the inferior oblique and the inferior rectus. The inferior oblique was laterally displaced 5.5 millimeters and anteriorized 2 millimeters in front of the inferior rectus insertion. It was secured with 6O vicryl sutures, detached from the globe, and it was then repositioned 5 millimeters posterior to the inferior rectus insertion, with the posterior fibers more posteriorly placed. And this was followed by a small 3.5 millimeter recession of the inferior rectus muscle because of the tightness I felt with the hook. Postoperatively, the patient was orthotropic in primary position, at good elevation in primary position, as well as good elevation in abduction of the left eye and good elevation in adduction. The second case is a 7-year-old child with history of bilateral strabismus surgery in early childhood. She had scars over both media recti and scars in the right inferior temporal fornix. She presented with right 16 prism diopters exotropia in primary position, 12 prism diopters hypotropia, as well as limitation of elevation in abduction of the right eye with an upshoot of the left adducted eye, as well as a V pattern. And on exploration, again, the inferior oblique was found anteriorized 2 millimeters in front of the inferior rectus muscle. It was repositioned 4 millimeters behind the inferior rectus insertion, and the medial rectus muscle in the right eye was advanced 4 millimeters from a 5.5 millimeter recession. Postoperatively, the patient was orthotropic in primary position with improvement of elevation of the right eye in abduction. The second topic I'm tackling is inferior oblique adherence syndrome. This is a restrictive motility disorder characterized by scarring of the inferior oblique to sclera or adjacent structures, leading to significant ocular misalignment. It can be caused by fat adherence syndrome. Fat adherence can occur with any type of inferior oblique surgery or with scleral buckling. It's caused by violation of Tennant's capsule with prolapse of orbital fat that instigates an inflammatory reaction that results in extensive adhesions that anchor the orbital periosteum to muscles and sclera. It can also be caused by inadvertent inferior oblique incarceration or scarring while placement of scleral buckles. And in the course of inferior rectus resections with scarring of the inferior oblique to the inferior rectus insertion, it occurs more commonly in patients with prior inferior oblique myectomy. Patients present with diplopia, large hypotropia, limitation of elevation in all fields of upgaze, restriction of passive elevation on forced reduction test. And in cases with incarceration of the inferior oblique to the inferior rectus muscle, there's also restriction of torsion and a large X-cycle deviation in primary position. Now, the aim of treatment in fat adherence syndrome is to increase the diplopia-free zone, move it to primary position, improve the cosmetic appearance of the patient. And it's also important to know that total restoration of motility is rarely possible. And it's always better to set realistic expectations for the patient. If the fat adherence is recognized in the acute inflammatory phase, then injection of botulinum toxin in the inferior rectus muscle will move the eye in a direction opposite of the anticipated restriction. This will act as a traction suture and will cause relative contracture of the superior rectus muscle, so that the inferior rectus will contract against a slightly tighter superior rectus muscle, and this injection can be repeated to avoid hypotropia. Whereas in the chronic phase, surgery or treatment entails surgical exploration in the area of restriction, careful dissection of adhesions, repeating force reduction test until it's normalized, inferior rectus recession, conjunctival recession, with the possible adjunctive use of intraoperative mitomycin C or amniotic membrane. The use of other barriers has shown to have limited success. Inferior oblique adherence, where the inferior oblique is incarcerated in the inferior rectus muscle, entails surgically releasing the incarcerated inferior oblique, repositioning it more posteriorly, or performing an inferior oblique myectomy if the inferior oblique is entangled with the scleral buckle, together with inferior rectus recession for inferior rectus contracture. So this is a 15-year-old patient who gave history of 4 previous strabismus surgeries, presented with left 20 prism diopters, hypertropia in primary position, and marked restriction of elevation in all directions of gaze. On table, force duction test showed limitation or restriction to elevation of the eye in all directions of gaze. Conjunctiva was incised, and there were extensive adhesions in the inferior temporal quadrant, and these were dissected very carefully, and then as well as the adhesions at the temporal border of the inferior rectus muscle. The inferior oblique was found in the inferior temporal quadrant, surrounded by extensive adhesions and fat, which was all dissected and removed, and inferior oblique myectomy was performed. This was followed by 4 mm inferior rectus recession, application of mitomycin for 2 minutes, followed by conjunctiva recession. Postoperatively, the patient showed some improvement of hypertropia in primary position, as well as in elevation, especially in adduction. The second case is a 35-year-old female with history of scleral buckling for retinal detachment in the left eye, with loss of vision in the left eye. She presented with 45 prism diopters left, esotropia, 25 prism diopters, hypertropia in primary position, with a marked restriction of elevation as well as abduction of the left eye. And she asked for surgery to correct the ocular deviation. Exploration revealed, again, extensive adhesions around the inferior rectus and the medial rectus, which were all carefully dissected. Contracture of the medial rectus and inferior rectus were present. They were both recessed. Conjunctiva was recessed with application of mitomycin C for 2 minutes. Postoperatively, the cosmetic result was acceptable, as well as there was improvement of elevation in all directions of upgaze, as well as in abduction. Amniotic membrane transplantation has been advocated for the management of restrictive strabismus. It reconstructs a tissue barrier that separates orbital fat and adhesions from muscle and sclera, as well as the fact that it can replace missing or contracted conjunctiva. So we performed a prospective study in our group that included 30 patients scheduled for strabismus reoperation to assess the efficacy or the role of cryopreserved amniotic membrane transplantation for strabismus reoperations. 15 patients underwent surgery with amniotic membrane wrapped around muscles, 15 patients without the amniotic membrane. There was no statistically significant difference in success rate or in cosmetically acceptable outcome. However, there was a statistically significant improvement inductions in the amniotic membrane group compared to the control group. This is a table that shows the clinical features that differentiate adherence from anti-elevation syndrome. And in conclusion, anti-elevation and inferior oblique adherence can both occur following inferior oblique surgery. Clinical examination for duction tests will differentiate between both conditions. In anti-elevation, inferior oblique recession 4 to 5 millimeters behind or posterior to the inferior rectus insertion is the required treatment. For scarring of the inferior oblique into inferior rectus recession, repositioning of the inferior oblique or myectomy with inferior rectus recession needs to be performed. For fat adherence, dissection of adhesions and inferior rectus and conjunctiva recession should be carried out with the possibility of adding mitomycin C or amniotic membrane. Complete resolution is difficult to achieve with fat adherence. Realistic expectations should therefore be set for patients. Thank you.
Thank you so much, Hala, for this interesting presentation on a very tricky subject, a very tricky strabismus. We have some questions, and one is, and I ask you if you can reply very quickly to have more questions for you.
Yes.
One is if you get ever anti-elevation syndrome after an inferior oblique myectomy.
Anti-elevation syndrome.
If you have experience on this.
I haven't seen that. I have only seen it when the inferior oblique is anteriorized in front of the inferior rectus muscle, because this is when it will start to be an anti-elevator. I haven't seen that with inferior oblique myectomy, but I've seen with inferior oblique myectomy fat adherence. I've seen that.
Listen, in unilateral anti-elevation syndrome, when only one inferior oblique was operated, a clinician may be in doubt if there is an anti-elevation syndrome on that eye or an overaction of the contralateral inferior oblique that was masked before the operation. Apart from the motility, have you some other tricks to really clear the situation, understand clearly the clinical situation?
Do you mean you want to know whether this is an inferior oblique overaction in the other eye?
Yeah.
Yeah, okay. It's really the limitation of elevation in abduction that will help you. So, and that you can see only with abductions, like if you cover the other eye and you try to move the eye up in abduction, it will still not elevate.
Okay.
And this is one of the pathognomonic things that I find.
Okay. And moving to the adherence syndrome, if you find orbital fat near the inferior oblique in a patient with adherence syndrome, what do? You cautery it, you excise it, you use triamcinolone, for example. What is your attitude?
Okay. If it's not a lot of orbital fat, what I try to do is to push it back and suture the tenon over it. And that's the best way, because when you start excising orbital fat, more comes your way and you get a lot of adhesion. So I prefer to try and push it back and suture tenons over it if I can. And that's what I usually use.
Cautery or excision mainly?
No, I don't like to use a lot of cautery. I would excise without cautery. Cautery will add more adhesions.
Well, I think we have time for one question more. And do you use imaging, orbital MRI, to detect features of adhesion, for example, in some patients, or you just go to the OR and see what's...
I do it clinically. I haven't done MRIs for patients with fat adherence. They're usually easy to identify, and then again, force reduction tests and exploration will show you.
Okay, thank you so much.
Thank you.
I'll give you the table.
Thank you, Hala, for this very nice talk, and we will move to Andrea Molinari. Please share your screen, Andrea, that she's going to speak on reoperations following transposition surgery.
Thank you so much, Rosario. And thank you, IPOSC, for having me here today to present this talk on reoperations after transposition procedures. And when are we going to reoperate a patient after a transposition procedure? Well, when we have a significant residual or consecutive deviation, when we have a symptomatic vertical or torsional disturbance, or when we have a vision-threatening complication. Basically, we're going to reoperate when we have an undercorrection, like in this case, when we have an overcorrection, when we have a new postoperative vertical or torsional deviation that was not present before the operation, or when we have a vision-threatening complication like a compressive optic neuropathy after a split lateral rectus muscle nasal transposition in a third nerve palsy. Basically, undercorrections are more frequently seen than overcorrections, and they can appear immediately after the transposition procedure or later on, like in this case. Overcorrections are less frequently seen, but they are more difficult to solve. In this series of 164 patients, 9 patients had an overcorrection that did not resolve spontaneously. And the result was better if they were reoperated soon. But in my opinion, overcorrections are desired after transposition procedure of 6th nerve palsy because most of them will resolve spontaneously. Look at this case that had a huge overcorrection, 30 prism diopters, but right after the procedure. But 1 week after the surgery, the patient was orthotropic. And you can see here 7 years after, the patient remains with a very small undercorrection. Induced vertical or torsional deviation can occur up to 27% of all transposition procedures. They usually resolve spontaneously, and small vertical deviations can be managed with prisms. You can use adjustable suture to prevent these complications, but when you use adjustable sutures, placing augmentation sutures might be very difficult. How are we going to manage an undercorrection after a full vertical transposition? Well, we can recess the medial rectus if it was not previously recessed, or we can re-recess it if it was previously recessed. We can add augmentation sutures, and if augmentation sutures were already placed, we can place more augmentation sutures posteriorly to the first one. How are we going to manage an undercorrection after a partial vertical transposition? Well, we can transpose the other half of the vertical muscles. We can recess or re-recess a medial rectus, and we can place augmentation sutures. If only a superior rectus transposition was done, we can then transpose the inferior rectus. How are we going to manage an overcorrection? Well, we can advance the medial rectus if it was previously recessed. We can gently release the augmentation sutures, or we can undo the transposition procedure. How are we going to manage a new vertical or torsional deviation? If this occurs after a superior rectus transposition and the patient has an intorsion and a hypotropia, you can transpose the inferior rectus. If it occurs after full or partial vertical transposition, you have to release the vertical force that is causing this vertical or torsional imbalance by releasing the augmentation sutures or undoing the transposed muscle responsible for this. If a new significant hypertropia is present, you can anteriorize the inferior oblique, as was done in this case report. And let me finish my presentation by showing you this case that presented to me a couple of years ago, or many years ago. This almost 2 years old girl presented to me with this anomalous head posture. And the history was that she had a recurrent 6-nerve palsy. Her first episode was when she was 4 months old that resolved spontaneously. She had another episode at 7 months that also improved, but her last episode occurred at 10 months and never improved. The girl had a esotropia of 35 prism diopters in primary position with an epiduction limitation of -5. So I operated her, and in this first surgery, I performed an augmented Hummelsheim procedure with resection of 4 millimeters of transposed muscle halves in the left eye, together with a recession of the left medial rectus of 4 millimeters. 15 days after this procedure, she had what I consider a desirable 15 prism diopters consecutive exotropia that resolved completely 1 month after the procedure. But she comes back 7 years later with a recurrent, esotropia, 35 prism diopters, and an epiduction limitation of -4. So I reoperated her, performing a re-recession of her previously recessed medial rectus. And let me explain what you see here. I'm hooking here the nasal half of the superior rectus, and here you can see the lateral half of the superior rectus that is inserting underneath the lateral rectus. Now I'm placing a 5-0 Mercilin suture 8 millimeters back from the insertion of the superior rectus, and I'm passing the suture twice and tying a knot in order to have it securely heft. So then I will hook the lateral rectus, and here you can see the lateral half of the superior rectus going underneath the lateral rectus. And then I measure 12 millimeters, like in an Ishida procedure, back and place this suture very close to the superior border of the lateral rectus and tied the sutures very, very tightly. The same procedure was, see here you can see this, the lateral rectus. This is the lateral half of the superior rectus underneath the lateral rectus. And the same procedure was done on the inferior rectus. 15 days postoperative, the patient had no more anomalous head posture. She was orthotropic in primary position, and her abduction limitation improved to -3 again. So to conclude, if you're going to reoperate on a patient that had a transposition procedure, try to obtain previous records in order to plan to make a better plan for the reoperation. You will need good visualization in these cases. Try to use the microscope. If the medial rectus is contractured, even if it was previously recessed, re-recess the muscle. You can increase the effect of a transposition adding augmentation sutures. In overcorrections, if you do not see improvement in a week, don't wait, reoperate. And if planning to do a nasal split transposition of lateral rectus, split very far posteriorly to avoid serious complications. Allow me to invite all of you to our next International Strabismological Association meeting that will take place in Buenos Aires in November of this year. And thank you all very much for your kind attention today. I will be very happy to entertain any questions.
Thank you very much, Andrea. It was absolutely fascinating. I have a question from the chat box. When you have an hypotropia after superior rectus transposition, when do you go for the surgery? How much time do you wait in this case?
Well, if the hypotropia is significant and the patient is really bothered about a vertical diplopia, I don't wait much, maybe 2 weeks, not more than that.
And if you have an horizontal overcorrection after a sixth nerve palsy, I have seen one that you have with 30 diopters and it recurs. Makes it different if you have a limitation of a deduction, or how do you manage that? Do you go immediately or you wait always?
Well, a limitation of adduction you might see very frequently. So I'm not get scared of a slight limitation of adduction. But for example, the case I showed, I was scared when I saw this patient, 30 prism diopters, because this is not the usual overcorrection I get. Usually I get 10 or 15 prism diopters of overcorrection. 30 is a lot. But I didn't reoperate immediately. I waited 1 week, and in 1 week, the patient was straight. So you have to see those patients probably more often. Don't call them 2 weeks afterwards. Call them a couple of days afterwards or 1 week afterwards, but not later than that. Because if the exotropia does not improve, and Hala can add a comment here because she was one of the authors of the paper I presented, it is better to reoperate sooner than later.
And which is the role of the transposed muscle in terms of a consecutive ICSO if you have in those patients?
What do you mean the role? When you transpose a muscle, you change the vector of the muscle.
Yeah. You remember a discussion we had with Jonathan Holmes, you know what I mean?
Well, Jonathan, what he said is that reoperations are very difficult because in many cases, the transposed muscles can stick into the sclera, and then it's difficult to undo the procedure. So that's why I recommended you always use the microscope in order to undo a transposition procedure.
Okay, thank you very much. There are more questions, but in terms of time, I have to pass the word to Giovanni.
Okay, thank you, Rosario. We move quickly to our last speaker today, with Professor Luis Ospina, working in Montreal. And I have to say what Luis asked us to say, that he is not anymore the current fellowship director at the University of Montreal. That was said during the presentation. Dear Luis, I have to say that I have a photo hanging in the wall of my office, and it's a photo where I am in this photo with Dr. Spranger and yourself and other friends, and we have a poster in front of us that was the official presentation of IPOSC many years ago at the American Academy. You probably will remember this picture. So it's a great pleasure to have you here and to talk about a very difficult topic, a very difficult reoperation. And so Professor Ospina will talk about reoperation in Duane syndrome. Thank you, Luis.
Thank you, Giovanni, for the invitation. And I think you're right, we've gotten older. Can you see it?
No.
Not yet. Yeah, now we are sharing, perfect.
Is it there now? Yes.
Yes.
So thank you again, and you're right, I think we've gotten older. Well, the subject is quite an extensive one, so I will have to concentrate on relatively common scenarios. Those will be three: hypocorrection after you've done recession of the medial rectus, overcorrection after the same operation, and I was going to talk about a bit about vertical strabismus induced after superior rectus transposition, but I think we'll probably be able to limit that because Dr. Molinari already talked about what is important in that regard. Now, so let's start with the scenario of a patient who has an esotropia residual or a recurrent esotropia after we have recessed the medial rectus. Two things are worth considering: the size of the deviation and the first ductions done on the medial rectus to address whether that muscle needs to be is tight or not. And according to that, we'll decide to operate or not on that muscle. Of course, a small deviation that is cosmetically good, we don't do much. But if we judge that an esotropia that measures less than 15 to 18 prism diopters needs to be reoperated, an option would be to recess the medial or go to the contralateral medial rectus to perform also a recession. That, of course, only if we are aiming at improving the angle and we're not looking to improve abduction. If abduction is going to be improved, we can consider doing a superior rectus transposition, and I'm not going to talk about vertical recti, the two vertical recti transpositions, because I don't do them in this context. But if you transpose the superior rectus alone, that's going to correct about roughly that amount of 15 to 18 prism diopters. Now, when the deviation is larger, you definitely need to think of combining the superior rectus transposition with augmentation sutures, and depending on the first ductions, of course, to also re-recess the medial rectus. One thing that is always important taking into account is the fact that overcorrections or long time overcorrections, exodrifts in Duane are not that uncommon. So anticipating that is perhaps wise to limit the amount of recession or re-recession that you do in your medial rectus, I would say about 5.5 millimeters. The other thing is that you have to always consider the field of binocular vision in every single operation you plan, irrespective of what you choose you're going to do. Now, I would say also the aim of these operations would be a slight undercorrection because of the same reasons. The exodrift may not be that infrequent. This slide with a graphic from Doyle and Hunter is just to remind you that the superior rectus, when you transpose it, you can adjust, and it's not that difficult. But also the augmentation sutures, you can adjust them. So that's very practical. And simply as a way to support the use of the superior rectus transposition in reoperations, let me remind you that when you combine that type of operation with a medial rectus recession, you are much less likely to have a residual esotropia, as it was done when you do a medial rectus recession. That was well demonstrated in the paper that I quoted here by Daggy and Hunter a few years ago. There is another paper from Magli, which is actually a very interesting paper because they used the superior rectus transposition only in reoperated patients. I think they operated 20 patients or so. And not only did they obtain good results in regards to the esotropia and the head posture, the main advantage with the superior rectus transposition, which is of course to improve abduction, was also seen in those patients, at least 30% of them. So if we look at this patient, who's a 40-year-old patient who had both medial recti recessed at 6 millimeters in childhood, he comes back at this age with a left esotropia. Well, it's quite a big angle, and if you think of the algorithm, you're immediately thinking that the transposition is going to be necessary, right? So one of the things we could do is, from the very beginning, as I said, because of the large angle, that's going to be an augmented transposition. But we need to remember that this is a patient who fuses in right gaze. So hopefully, because the angle is so large, we're going to have to add some medial rectus, some work on the medial rectus. But if you think about it, that's a muscle that has already been recessed to 6 millimeters, and any additional recession is going to affect his field of binocularity in the direction in which he fuses, which is right gaze. So hopefully, if the muscle doesn't feel very tight on forced ductions, as I said, those are key, it might not be a bad idea to recess the contralateral medial rectus, because that way we're going to be matching the abduction defect of the left eye without sacrificing his field of binocular vision, which is, of course, very important for him. This is just a video to show you that he's a good candidate for the superior rectus transposition. Why is that? Because there is no significant globe retraction, because there are no upshoots or downshoots, because there is no limitation in right gaze, and he happens to also have an A pattern, so very convenient. So let's switch scenarios to the opposite situation, a patient who develops an exotropia after recessions of the medial recti. That can occur because of over-recession, also because when we recess the medial rectus, we can create fixation duress, and we can expose and expose, let's say, the misinnervation in the lateral rectus and cause some sort of synergistic divergence. And the third reason will be simply because over the time, we know that Duane cases, the lateral rectus can simply become tighter as time passes. So how to deal with these patients? The algorithm by Federico Vélez and Pinellas is actually a very practical one. It takes into account the nature of the operation that was done first and the first ductions on the lateral rectus. So when a medial recession has been done and the first ductions on the lateral are negative, it does make sense to advance the medial rectus. But if the first ductions are positive, of course, we have to recess the ipsilateral lateral rectus. Now, if the operation was combined with a superior rectus transposition, the principle also applies. If the first ductions on the lateral are negative, it makes sense to explore and hopefully advance the medial rectus. But if it doesn't feel tight, a revision of and relaxing the transposition is going to be necessary. It's also important to notice that sometimes the tightness will come from the lateral rectus, so that muscle will have to be addressed as well. Again, any surgical plan needs to consider the field of binocular vision in the patient. We need to preserve it or even try to increase it. Let's think of this patient with bilateral Duane. He was esophoric. The bilateral makes things way more complicated, but at a younger age, the parents were very bothered by the fact that the globe retraction was severe. In their words, the eye was closing all the time. So we did a left lateral rectus recession of 8 millimeters, accompanied by a right lateral, medial rectus recession of 6 millimeters. The globe retraction improved quite a lot. The good alignment remained there for about 10 years, but this is what happened years later. He comes back. This is the same patient at age 19 with neck discomfort from a right head turn. There is recurrent globe retraction, and of course, he has a consecutive exotropia of about 16 prism diopters. An exodrift has occurred, and because this has happened slowly over time, I think it is reasonable, thinking of the algorithm I just showed to you, to assume that we're going to find at least some level of tightness in that lateral rectus. So we need to probably perform a substantial re-recession of that muscle. But that's not going to be enough, because if we think about it, any sort of over or more recession that we're going to do in that muscle is going to shrink his field of binocular vision precisely in the direction in which he fuses, right? So it's important to take that into account and to remember that the medial rectus had already been recessed. So we're going to be limiting not only a deduction in this patient, his abduction to start with was already very limited. So hopefully, and I'm actually very glad because Dr. Cioplean addressed that, I wouldn't mind exploring that medial rectus, and hopefully we're going to find some room to re-advance it. And sometimes there is a stretched scar would be also convenient to address that problem. Why do that? Simply because hopefully by doing so, we're going to be expanding his field of binocular vision in right gaze once we have limited what he had, which was a good better visual field of binocularity in left gaze. The last case I had has essentially been discussed by Dr. Molinari, is the case of a vertical induced after superior rectus transposition. And I think she made the point I wanted to make today. The advantage is that when we use adjustable sutures, we can perform the reoperation right away, literally hours or days after we have done that operation, in case there is a hypertropia that needs revision of the transposition. Why do that? Because otherwise scarring is going to be terrible and the operation is going to be very difficult. Of course, not every single case needs to be addressed, because some are very mild or will fix on their own, or also because some of especially the hypotropias have been demonstrated to be pre-existing hypotropias that do not necessarily need to be addressed because they occur only in side gaze where the patient did not have previous fusion, so it's not necessarily very bothersome. So that's essentially what I had. I think every time we reoperate on a Duane patient, a careful examination needs to be combined with proper assessment of the first surgery done. We need to do proper transductions, and also essential to consider to take into account the field of binocular vision. If possible, try to use adjustable sutures. Thank you.
Thank you so much, Luis, for this excellent presentation. Unfortunately, we're a little bit on delay, but I have a question for you, and which is the following. If you are doing a superior rectus transposition for a recurrent ET in Duane, ET of 18 or 25, as you previously talked about, which is an indication for superior rectus transposition, do you do anything at the same time to try to avoid future overcorrection? I mean, you re-advance the medial, you look to the medial if it was not you that operated the patient.
Yeah, I think the first deductions will probably give you the answer, but the truth is that, as I said, up to 15 prism diopters, only the transposition might be enough. Beyond that, and you're talking about a patient with 25, I would try to do some extra work there, no doubt. Depends again on the first deductions, because if the first deductions are positive for the medial, we're not going to obtain the amount by doing only the transposition. So in theory, that muscle needs to be re-recessed. But I would be very careful not to go further than 5.5 or 6, because then I'm going to end up with an exo drift. So in that case, I would probably just go to the contralateral medial rectus and hopefully do it under an adjustable to add some extra correction, because the angle is beyond the 20, it is 25.
Yeah. And you agree that in general, in Duane syndrome, undercorrection is always better than overcorrection?
Definitely. Let me
You
just tell
aim
you.
an undercorrection always in your surgery. Is it correct?
Yes. And not only when you're operating. I'm going to tell you an anecdote. A couple of weeks ago, I saw a patient at age 19 or something like that. And the eyes were straight. That's a type 1, very common Duane syndrome. And I felt very proud. And I said to the mother, "When did I operate your girl?" And she said, "Dr. Ospina, you finally never did the operation." I went back to the records, and this is a patient who had an esotropia of 20-25 in primary, and the exodrift occurred. So those lateral recti in Duane syndrome can become, it can change over time. They can become tighter.
Okay. Thank you so much, Luis. Rosario, what do you think?
Yes, Luis, can you stop sharing the screen in order that we can conclude? Well, it's very sad, but we have to conclude this fascinating webinar. I have to thank all the panel that had participated today. Thank you very much for your time and for your expertise. I also have to thank the audience to be so active on the chat with the very many questions. The ones who are not there are going to be answered afterwards. It was a privilege to learn from you. And I just have to announce the next webinar, who has a very attractive title, What if the patient have diplopia? But it has also a very attractive roof-up panel. And if we go to the next slide, and for the ones who could not attend or want to see those webinars back again, please go to the web. All the webinars are going to be recorded, and they are very interesting to see them afterwards. So with that, I just have to thank you very much. Thank you, Giovanni, for co-chairing, and Tamara for being behind helping us. Thank you very much, and I look to see you on the next webinar. Thank you.
See you. Bye-bye.
Thank you.